A temporary tracheostomy is performed in emergency situations to bypass an airway obstruction. The ventral neck is clipped and the patient is placed in dorsal recumbency. Extend the patient's neck and make a midline incision about 2 rings below the larynx. A 4 to 5 centimeter ventral midline skin incision is made caudal to the cricoid cartilage. The sternohyoideus muscles are bluntly separated. Dissect down to the trachea, taking care to avoid damage to the tracheal cartilage. The incision in the trachea is made between the 2nd and 5th tracheal cartilages. The simplest incision to make is the transverse annular ligament incision. Two large sutures of non-absorbable material should be placed at the edges of the tracheal incision to allow easy access to the trachea should the tube become dislodged. A tracheostomy tube of appropriate size is inserted into the trachea until the cuff sits against the neck. In an emergency situation, any metal, plastic, or rubber tubes may be used. However, a commercial tracheostomy tube should be placed as soon as possible. Cuff tubes may cause necrosis of mucosa and are used only if mechanical ventilation is required. Cannulated tubes allow for periodic removal of secretions. Next, the tracheostomy tube is placed into the trachea. The tube used should be of the appropriate diameter so the animal can breathe around it if blockage occurs. The sternohyoideus muscle and skin are closed around the tube with simple interrupted sutures. Antibacterial ointment is placed at the skin-tube interface. The tube is tied to the neck with gauze or sutured to the skin. After the tracheostomy tube is placed and secured, the patient will require 24-hour care. 5 to 10 milliliters of sterile saline should be placed into the tube and secretions suctioned off on a regular basis. Remove the tube as soon as possible and allow 2 to 3 weeks to heal by second intention.